Hello, hello, hello. Good evening, students. Good evening. Uh, from where we are streaming, there would be some lag. So just wanted to once we get a confirmation, are we live? And then yes, I think we are live now. Can all of you hear me? Can all of you see me? Am I visible to all? Am I audible to all? Yes, I think we are live now. Yes, and is the chat box also working properly? Can I get something in the chat box if somebody can type in so that I know that the chat box function also fine? And can all of you hear me and can all of you see me clearly? Dr. Sumanta Pathak, Vineet, yes. Thank you all of you. Yes, Dr. Nitin Bhat, yes. Okay, so welcome all of you to our session. This is the FMGE quiz. We will be basically discussing some of the important MCQs for the upcoming FMGE examination in the form of quiz, and I want all of you to participate in the exam, in the quiz, and answer the questions. Right, wrong does not matter. We'll try to cover lots of important MCQs. These are all the previous year's questions, high yield MCQs, extremely important likely questions, and all of you will really enjoy, is my guarantee, and get a lot of information, because we will not only be discussing the MCQ, lots of other related topics also we will be discussing. Okay, but just a couple of things before we begin. So Unacademy NEET PG, all of you are aware, please download the app, and this is the ultimate NEXT batch, which is for the upcoming 2024 examination. You get notes plus vitals is a complete set of recorded classes. Okay, and use the code mentor, MENTOR. All 19 educators including me will be there for OBGY, and use the code mentor to get discounts. Similarly, this is, I want all of you, it is a med scholar test series, 200 question, 19 subjects. This is on 21st of May from 10 a.m. to 1:30 p.m. Okay, so there are lots of exciting rewards. I want all of you again to please participate in this test. It is, I repeat, it is on 21st May, 10 a.m. to 1:30 p.m. And lots of 100 plus learners have already cracked the NEET PG examination, including FMG, lots of results. This is the FMG last mile preparation, which is already started. All of you, those who haven't yet subscribed, please go and use the code mentor to take the subscription, so that you get the maximum benefit. I will be covering the OBGY, and there's also the NEXT batches. So lots of batches going on, live lectures as well as recorded classes are available, and all of you know the advantages. You will get both live lectures, recorded classes, best teachers, anytime, anywhere, any device of your choice, and notes also available. Iconic subscription is also available, which is the best of both the worlds. And this is something really very important, complete recorded studio recorded lectures, excellent lectures, NEET PG vitals. I can assure you that all 35 to 40, OBGY is a major subject, and you get 35 to 40 questions in your FMG exam. Students have passed FMG, cleared FMG thanks to the OBGY. They said it's by cracking OBGY we are clearing the exam easily, and all 35-40 questions every year in FMG are from our lectures. So all of you make the maximum benefit out of it. Okay, so just download the app, use the code mentor to get the discounts. Okay, so with this we start our discussion, and now I want all of you to answer the first question. LH peak precedes ovulation by. Okay, yes, all of you, I want you to answer. Right, wrong does not matter. Please participate in the poll. Rahul Bishnoi is saying option C. Vineet Dhamane, 36 hours. No, please read the question correctly. It is, we are talking about the LH peak. Okay, not the LH surge onset. All of us know that LH hormone is responsible for ovulation. Okay, from the HPO axis. Okay, yes, Sumanta Pathak, very good. Okay, so now all of you please pay very careful and simple attention. This is extremely important. All of you should know the basis of the HPO axis, hypothalamo pituitary ovarian axis. Okay, so we'll not only discuss one MCQ, lots of other important MCQs around that also we discuss. So pituitary is the master, ovary is the servant. Pituitary sends the first signal FSH or follicle stimulating hormone. Based on that, from the ovaries the follicle starts growing. Okay, within the ovary there are the follicles. Now can anybody also tell me that the follicle starts growing? The growing follicle is secreting which hormone? So the growing follicle is secreting estrogen. So the estrogen level is rising, and when a particular level of estrogen is reached, that sends a positive feedback to the brain to secrete the LH hormone, luteinizing hormone, and that will finally cause ovulation to take place. Now I want all of you, simple thing, please all of you understand that yes, we know LH hormone is going to cause ovulation. LH surge, from the onset of LH surge to ovulation, it is going to be 36 hours. But that's not the question over here. From the onset to reach the peak is the maximum levels, it is going to take around 24 hours. And once the peak or the maximum levels are reached, in another 12 hours the ovulation will take place. Simple maths, 24 plus 12 is 36. Is this understood to all of you? Clap if you feel happy. So what am I saying? One simple figure, 3 MCQs discussed already. Can all of you understand? So if the question is from LH peak precedes ovulation by, that means how much time before LH peak precedes ovulation, that means once the peak is reached, then will the ovulation take place? The answer is 12 hours. Okay, is this understood to all of you? I repeat, now suppose if I change the question and if I write instead of LH peak, all of you now tell me the answer. So see how the variation, one question 3 different answers. Now if I ask you instead of LH peak, from I say LH surge onset to ovulation, now what do you think will be the answer? All of you, from the onset to ovulation, now what all of you will mark? Yes, excellent. Suman Patak, Rahul Bishnoi, Nitin Bhati, all of you correct. Then the answer becomes 36 hours. Okay, so please don't make a mistake. These are very simple MCQs and I hope all of you have understood the concept. So I repeat the original question, LH peak precedes ovulation by 12 hours. Just keep this simple figure in mind. From the onset, clap if you have learned something new. Very from the onset to ovulation, entire is 36 hours. Onset to reach the peak will take 24 hours, and once the peak is reached in 12 hours the ovulation will take place. Is this understood to all of you? Very important MCQ. Please don't make a mistake in this question. Moving on, anybody identify the device first. What is this picture based MCQ? And the hormone released per day from this device is how much? Beta Ruchi Shukla, you are just in time. We have just discussed one very important MCQ. With that, we discussed 3 variations. So, as such, 2 to 3 questions discussed. Yes, very good. Irina, can anybody give another name? Parma Sivam P. Beta progesterone, better your answer. Which type of progesterone? Only progesterone, vague answer. I want a specific answer. Which type of progesterone? No, it's not a progesterone, sir. रुचि शुक्ला, no, wrong. थोड़ा सा ध्यान से समझिए. Okay, so first of all, anybody identify the device, and the question is hormone released per day. We are not asking the total, how much is released per day. Very good, Shalini and Yashwant. Yes, so this device is called Mirena, but Mirena is a brand name. Another name is LNG. Okay, It is a, no, it is not a copper T. Always, okay, copper nahi hai. Okay, I'll come to that. Okay, so it's a LNG intrauterine device. Please understand, all of you, that do you see any copper wire? No. All of you pay attention. Just in the copper T, there will be a copper wire. In a copper T, there is a copper wire wound over here. So this is not a copper T. Okay, there is no such copper wire seen over here. Is this understood to all of you? This is a completely white barrel. This is, okay, this is called as LNG intrauterine device. Very good, Yashwant. Okay, LNG intrauterine device, also called as myrin. It's a method of birth control. So MCQ number 1, what does it release? Sir, it releases levonorgestrel. Now, two separate questions. What is the total LNG content? So total LNG is 52 milligrams is the total LNG, but the question asked is how much is released per day, and the answer is very good, 20. Again, between B and D, don't make a mistake, it is 20 micrograms. So option B is the right answer, 20 micrograms. Can anybody tell me it is effective for how many years? How many years? So 52 milligram is the total content. So two separate questions can be asked. Totally 5 questions could be asked to you. I'll tell you which one. Effective for how long? How long can I use it? 2 years, 3 years, 5 years, 10 years, if I ask you. And that is why also remember one more name, it is called LNG20. It's also called as LNG20. Why do I call it LNG20? Because it releases 20 microgram every day. Very good. It is up to 5 years. Okay, 5 years is this, and it's one of the highly effective method of birth control. The failure rate, I've never seen it fail, is only 0.09 to maximum 0.1% is the failure rate. Okay, so again, one MCQ, 5 extra information. Please all of you pay attention. It is called as LNG intrauterine device, also called as LNG20, also called as Levonova. Why? Because sir, totally it contains 52 milligram LNG total. So again, if the question here is changed, and instead of hormone released per day, if I ask total hormone content, hormone total is how much, your answer will become 52 milligram. So this is how, please read the question correctly. But here they haven't asked you per day, they have asked you per day and not the total. Okay, hormone release per day, clearly it is asked per day. Okay, so I need to hormone released per day, and therefore the answer is not 52, it is 20 microgram. Okay, and you can see 20 microgram per day is released, which is the answer over here, effective for 5 years, and the failure rate 0.09 to maximum 0.1%. Can anybody tell me the non-contraceptive benefits and uses? This device has got lots of other benefits. Apart from contraception, where can I use it? Anybody? What will happen if I continuously, it releases progesterone inside the uterine cavity. I put it inside the uterus, and inside the uterus it is releasing only progesterone, 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 progesterone. Every day 20 microgram. So what will be the benefits and uses? Can anybody tell me? Very good. It can decrease the size of fibroids. Yes, okay, progesterone. What else, Yashwant? Anyone else? What else? Which condition? Which cancer can it prevent in the long run? And what are the main uses? Which is the one main condition where I can use this device? Okay. Very good. Okay. Endometriosis, Prakhar Keshri, and remember students, I can use it for menorrhagia. Menorrhagia, or also called as heavy menstrual bleeding. Why? Because sir, when I continuously give progesterone, what happens is that the lining is not allowed to grow. The lining grows under the influence of estrogen, the endometrial lining. So the lining remains very, very thin. What happens to the menses? So the menstrual bleeding can become less scanty. It causes the periods to become scanty. So that's an added advantage, and periods can also stop temporary. Okay, so main use is for management of menorrhagia, and very good, since it can also use for prevention and treatment of endometrial hyperplasia, endometrial cancer, और प्रखर केशरीय से. So remember benefits, mainly remember menorrhagia, decrease the size of fibroids, prevention and treatment of endometrial hyperplasia, prevention of endometrial cancer, and also endometriosis. Also I can use it in endometriosis. All this is discussed in our actual classes into your, because it causes the continuous progesterone. So because of progesterone, the estrogen is not allowed to act. Progesterone is opposite of estrogen, counteracts estrogen. So lining remains very, very thin, and patient can also reach a state of amenorrhea. So those who have got heavy periods are very comfortable with this amenorrhea, or little bit bleeding, spotting can happen, but mainly the menses will come under control. So it will not be very heavy for the patient. Okay, so please keep all these points in mind. Each and every line what I'm talking is an important MCQ. Moving on, again a very, very important, if I want to do the blood test, okay, blood test, when I want to do, to sample LH FSH levels in the serum, okay, serum FSH and serum LH. Volume better, this is maximum volume. Rahul, now it's okay? Yeah, I'll just be loud enough, okay? Ruchi, just you can also try to please increase the volume of your device. Yeah. Okay, so this is again a very, very important mistake, and many students make a mistake in this. Please understand, always read the book by the specialist. Many students feel that the answer is day 12, day 14, day 6, day 8. Wrong. Very good. So please understand this, that whenever I want to do the blood levels of FSH and LH hormone, we would want to know the level at the beginning of the cycle. We want to know the baseline level. So on day 2, day 3, please remember this, those who want to become gynecologist or a pathologist, remember this lifelong. Very good. Yashwant and Dr. Khush Avasti, Shalini Subhash, yes, all of you correct. So remember students, the answer is that I need to do the level at the beginning of the cycle on day 2, day 3 of the cycle. The reason nobody is going to ask you, but as the cycle will progress further, the levels are going to increase. Yes or no? FSH will keep on rising, LH surge will happen. So if I do it later in the cycle, we are going to get a falsely elevated reading. Okay, we'll get a high levels. If I do it on 12th day, 14th day, 8th day, we'll get a very, very high level unnecessarily. So I want to know the baseline level. So the reason you're not supposed to remember, but remember FSH should always be done on day 2 or day 3 of the cycle. Okay. Beta Ruchi Shukla, 100% my guarantee. You listen to my 50 hours, you will thank me, is my guarantee. Ruchi Shukla, मेरे जो 55-60 आवर्स के नीट पीजी वाइटल्स के ऊपर लेक्चर्स हैं, आप देखिए, 1.5 month you can finish all the lectures and you will thank me on the day of the exam, is my guarantee. 40 questions will come and you will pass your exam thanks only to OBGY. Without wasting any time, listen to my entire lectures on NEET PG Vitals, and all 40-50 MCQs are going to come from that 45-50 hours of lectures. This is my guarantee. Okay, yeah, I'm coming to that. Okay, day 2, day 3 is yes. Okay, so point number one is, what is the meaning of day 2, day 3? Whenever the periods start, that is called day 1 of the cycle. So if today the patient period starts, the next day, on the second day, or on the third day, yes, that means day 2, day 3 will almost give you the same response, same results. Okay, is this understood to all of you? Yes. Yes. Okay, so on day 2 or day 3 of the cycle, you need to do the blood levels. One more MCQ: what is the normal When I do FSH to LH ratio, the normal is 2:1. And can anybody tell me what happens to the ratio in PCOS? In a patient of PCOS, polycystic ovarian syndrome, again a very important MCQ, what happens to LH-FSH ratio? Okay, so remember day 2, day 3 means when the period starts, that is called day 1. So after that, the next day, she can do. Yes, very good. So the FSH to LH ratio will become 1:2, or it could be 1:3, or sometimes even 1:4. Yes, because the LH is going to be very, very high in a patient of PCOS. Is this understood to all of you? So remember this, you again, lots of MCQs are there. Okay, I'm writing again for all of you that normally, okay, three MCQs discussed with this, that sir, FSH LH, FSH and LH blood test always to be done on day 2 or 3 of the cycle. That's the first MCQ. Normal patient, okay, normally if I do FSH upon LH, the ratio is 2:1. This is normal. And what happens to the ratio in PCOS? It is called inversion. Simple MCQ, ये भी MCQ है, flipping of the ratio or inversion of the ratio, or it could be 1:3, or it could be 1:4. The reason is FSH is generally normal, but in PCOD the LH becomes very, very high, and therefore you are going to get this kind of a ratio. All these are extremely important MCQs for your entrance examination. Okay, so day 2, day 3 you do the blood test. One more very important, difficult, high level MCQ. Can anybody tell me, if I do day 2 FSH, what information can it give me? FSH levels on day 2, if they are normal, very good, it's a good sign. But if FSH is very, very high on day 2, if I do a patient's day 2 pay FSH, it is very, very high, can it tell me something? What is it a marker for? Again, a very difficult MCQ for FMG. It has come in the NEET PG exam. All this is discussed in my lectures. Yes, so please understand that FSH hormone is a marker for ovarian reserve. Okay, ovarian reserve means what is the capacity of the ovary to produce eggs. Okay, yeah, Yashwant, better than that. Okay, so correct. So S, Dr. S and Dr. Nitinwal, yes, that sir, if the FSH is very, very high, that means patient's ovarian reserve is very, very low, and that indicates that she is going in early ovarian failure, or basically ovaries have also stopped function, like an early menopause. So ovarian reserve means capacity of the ovary to produce eggs. So when the FSH is very, very high on day 2, it is not a good sign. It tells me that the patient's ovarian reserve is very, very low. That means she is nearing menopause. She is very near to her menopause. That means her eggs are depleted. And when menopause is already arrived, at that time FSH is the highest. So very, very high FSH indicates that patient has already reached menopause. Okay, ovaries have completely stopped function. That's just, by the way, some corollary to the same rule. Okay, so that is just, by the way, extra information which I have given you. Yes, again a very, very important topic of pre-eclampsia, eclampsia, because again on this one MCQ comes for sure. In a patient of eclampsia, when we give magnesium sulfate, all of you know magnesium is a drug of choice, what is the therapeutic level to be achieved? Very good, Samir, very good, S, Dr. S. And the answer is, Pritchard regime is one of the regime that also will discuss, 4 to 7 milli equivalents per liter. This is the levels at which the conversion will stop. Okay, now 3 more things. Can anybody tell me, point number 1, when I give magnesium sulfate to the patient, what are the 3 things that I will monitor? I need to monitor something. So what all will I monitor? Yes, yes, yes. Come on, come on, come on, students. In the patient. Very good. So we need to, yeah, blood pressure we will of course monitor, Yashwant, but other than that, okay, respiratory rate, very good. What else? Knee jerks, very, very important. Knee jerks we need to monitor. That is your deep tendon. Very good, Dr. Jai Vignesh. Deep tendon reflexes or knee jerks I need to monitor, and I need to monitor the urine output. Please by heart this. Okay, urine output. Why? Because magnesium sulfate is excreted by urine, and if the urine output is lesser, patient can have magnesium sulfate toxicity. Urine output should be at least 25 to 30 cc per hour. Okay, urine should be at least 25 to 30 cc per hour. So I repeat, the patient we need to monitor respiratory rate, knee jerks, and urine output. Are three things we need to monitor. Now, very good. And as the levels become more, 8, 9, 10, 11, 12, there could be problem. There could be cardiorespiratory paralysis. First of all, the knee jerks will become abolished. Okay. And there could be also respiratory and cardiac failure and arrest. Okay. Yes. And very good. What is the antidote or drug of choice for magnesium sulfate toxicity? If they ask you magnesium sulfate toxicity, then the drug of choice is calcium gluconate. So all these are the important MCQs which we need to remember. Still not over. Please tell me the dose of magnesium sulfate. Can anybody tell me what is the dose? What is the loading dose? Yes, yes, very good. So loading dose is how much? Loading means initially you have to give. Very good. S and Rahul Vishnu. Okay, so remember students that I will give 4 grams IV. Slowly, 4 grams IV and 5 grams plus 5 grams IM in each buttock, because it's a very big quantity. If you give 10 in only one buttock, it's going to cause a lot of problems. So we give divided, and 5 gram on one buttock, 5 gram on another buttock. So we give IM. Okay, so if you see 4 plus 5 is totally 14 grams. Okay, 14 grams is the total initial dose, or also called the loading dose, and then the maintenance dose. Maintenance is you give only 5 gram IM. Okay, you keep on giving 5 gram IM in each buttock till, okay, till how much? Okay, so you keep on giving. Okay, so 5 gram IM in each buttock, you keep on giving 5 gram till how much? Okay, yes, each buttock, correct, very good. So magnesium sulfate is to be given till 24 hours after delivery. Don't stop it at the time of death. You continue till giving it for 24 hours after. Yes, this is the Pritchard regime, correct. Okay, this is the Pritchard regime. 14 grams IM loading dose, and then 24 continue to 24 after delivery, or 24 after last conversion. So all this very, very important. Remember, it's grams. Okay, grams, not milligrams. 14 grams. And 4 to 7 is the level which you need to maintain. Okay, is it clear to all of you? Yes. Now a match the column kind of the question, think and answer. On one side I have got the different methods of birth control, and here I have given the failure rate, and you need to match the column. Yeah. So I'll just clarify, the initial dose is 14, and then 14 grams initial dose, and maintenance is then 5 gram alternate buttock you give it. Okay, when you give it in both the buttocks, 5 gram, and then you need to give in one side, like that. You keep on giving it. Okay. Yes. So now please understand this, that the male condom, okay, male condom, very high failure rate, 4 to 14%. Male condom has a high failure rate, 4 to 14%. So one is going with D. Is it clear to all of you? One is going with D. Okay, so 1A is out, 1B is out. Copper T is copper containing intra IUCD. Very good. It has a failure rate of only 0.5 to 1.5%. 0.5 to 1.5%. So 2 is going with A. 2 is going with A. Okay. LNG IUD we just now discussed. LNG IUD is what? Our Myrina. And I told you Myrina has a failure rate of only 0.09 to 0.1. Yes or no? I just now told you today only. So 3 is going with C. Very good. And a diaphragm has got a very high failure rate. Diaphragm has got a highest vaginal diaphragm, 18 to 25%. So 4 is going with B. Very good. So all those have answered B. 1D, 2A, 3C, 4B. So with this one MCQ I have discussed 4 another MCQs. Okay, is it clear to all of you? So please keep in mind that male condom 4 to 14%. Okay, so male condom is 4 to 14%. Female condom is again 8 to 18%, but diaphragm is very high, 18 to 25%. Copper T 0.5 to 1.5%, and LNG IUD has one of the least failure rates, 0.09 to 0.1%. Okay, is it clear to all of you? So clap if you have learned something new on a Friday evening, and this is very important. Okay, because all this could be asked to you. Okay, now moving on to the next question. Yes, identify. Yeah, okay, yeah, identify this image. This is a ultrasonography of the uterus. This much they will tell you, that ultrasonography of the uterus is performed, and what is it showing you? Yes, very good, all of you. Prakhar, Yashwant, S, Vishnu, S, all of you correct. Yes, so this is a very important MCQ, and this is the multiple inside the uterus. All of you can appreciate multiple. See, can you see this small multiple fluid filled grapes like vesicles? So this is our typical very famous MCQ, snowstorm appearance. Snowstorm appearance, and it is also called, therefore it is a vesicular mole, V mole or hydatiform mole, or also called as H mole. So vesicular mole or V mole, multiple free. Yes, very good. Molar pregnancy, also called as molar pregnancy. And I don't see, can anybody tell me, is it a complete mole or a partial? Sir, I'm not able to see any fetal parts, so this is a complete mole. Okay, complete vesicular mole. So what's the difference between the two? It's, sir, in complete mole only multiple fluid filled grapes like particles are seen, and in partial mole, so it's called snowstorm. And partial mole मतलब क्या है? थोड़ा baby थोड़ा grapes. Okay, so baby is also there, and grapes is also there. So when you see some fetal parts, so kya hai name of the movie? Thoda baby thoda grapes. Okay, so either when you see the fetal parts, then this is a partial mole, this is a complete mole. Okay, now anybody please understand this. Of course ossipils has got no role. Please, we are not supposed to do a cesarean section, so never say cesarean section. Okay, we are not supposed to cut the uterus and remove it. And can anybody tell me Why should I never induce labor? Why not go for induction of labor? Never. What will happen? What will happen? Yeah, so the reason being that it is not a well-formed pregnancy. If I make the uterus contract, no, embolism से भी ज़्यादा better doctors, embolism yes can happen, but if I make the uterus contract, what will happen is few grapes will come out and lot of the grapes can remain inside and there could be a lot of retained products. So under one shot, so don't make the uterus contract initially, you suck out all the pregnancy and then yes you can give oxytocin. So we are supposed to do suction evacuation. So dilatation and evacuation or suction evacuation you do, and this is irrespective of the size of the uterus. Please understand this, that normally we do a suction evacuation only till 12 weeks in a normal patient. MTP, remember this, MTP, when I want to do up to 12 weeks, we use suction evacuation. The biggest exception to the rule is V-mole. That sir, in V-mole, whatever may be the size of the uterus mentioned to you in the question paper, whether they tell you it is 18-week size uterus or 24-week size uterus or 36-week size uterus. Is this clear to all of you? Whatever may be the weeks of gestation, whatever may be the size of the uterus, uterus could be 18 weeks, 24 weeks, 36 weeks, still the answer is only suction evacuation. Is this understood to all of you? Yeah, Jai Vignesh, don't say DNC. DNC is dilatation and curate, dilatation evacuation. Okay. So in a normal MTP, only up to 12 weeks suction evacuation is allowed, but vesicular mole is an exception where whatever be the size of the uterus, the treatment is suction evacuation, and that is what I need to do. Very, very important. After sucking out the grapes like particle, what do we monitor? Again, a very important to the MCQ asked in the last year FMGE exam. Anybody? What do I monitor? How do I follow up a patient? Very good, all of you. S, Samir, all that. That's the beta HCG need to be done after suction evacuation. So first you will do initial level and then you will keep on doing it every weekly till it becomes okay. So HCG should keep on becoming less. Okay, it is very, very important. Yes, until the levels become lesser, and then you keep on doing it also monthly till at least 6 months. Okay, minimum 6 months follow up is required. Okay, so the HCG follow up you need to keep on doing to make sure that the levels are coming down. So whether it's a complete mole or partial mole, the treatment is suction evacuation. One more important MCQ. Yashwant, because in vesicular mole the HCG levels are very, very high. So once I have sucked out all the pregnancy, we need to make sure that the HCG has dropped down, because there's a chance that if it is not dropping down or plateau, then other agents, methotrexate, because there's a risk of developing of choriocarcinoma. Okay, Ashwan. So beta HCG levels need to be monitored and make sure that it has come down to normal. Okay, because it is, what is this? It is a benign condition with malignant potential. Vesicular mole is not cancer, it may become cancerous. So it's a benign condition, gestational trophoblastic neoplasia, as you know, it's called as, it's a benign condition, but it has a malignant potential. So we need to make sure that the HC levels are completely dropped down. Okay, one more very important MCQ. Can anybody tell me the karyotype? What is the karyotype in complete and partial vesicular mole? कंप्लीट मोल कैरियोटाइप क्या है एंड पार्शियल मोल क्या है? Yes, so complete mole, the most common karyotype, it is 46XX followed by XY. And partial mole, anybody? Partial mole is what? Partial mole is always triploidy. Keep this point in mind. Yes, it has got 16:9. Okay, so this, please keep all these points in mind. Yes, very good. Devar Shigora 46xx is main, 46xy also you can get, but xx is more common than x. Okay, and this is 69. Okay, yes, so keep all these points in mind. Okay, next extremely important MCQ, 100% coming, quadruple marker test. What is this test? Why do I do it? And what is the answer? Okay, so anybody, what is this test for? S. Yashwant Alok. Yes, very good. Anybody, what is this test for? Yes, med psycho prakar Keshri all right. Yes. So chalo. And at what weeks of gestation do I do it? Lots of information. So again, first of all, for knowing quadruple marker test, we'll also tell you triple marker test. Anybody? So what is this test for? So this is in what? So this is in the serum. How do I do this test? Anybody? How is this test done? How is the quadruple marker test performed? Anybody? Amniotic blood, amniotic fluid, fetal blood, maternal blood. How is the test performed? So point number one, it is a screening test. Very good. It's a screening test. And no med psycho. I was waiting for that answer. Not on amniotic fluid. Please understand, amniotic fluid, when you take out, it's a confirmatory test. This is Yashwant wrong. Med psycho wrong. Okay, no problem. All of you here, we are here to make mistakes, no problem. But don't make the same mistake in the exam. It's a simple screening test done on maternal serum. Just take mother's blood. Okay, so maternal serum is the sample to collect the test, and it's a screening test for what? It's a screening test for Down syndrome, trisomy 21. Okay, in amniotic fluid you will get karyotyping, which is a confirmatory test. Okay, so don't make a mistake. Quadruple marker test is a screening test done on serum of the mother. When do I do it? Amniotic fluid or amniocentesis. When I do, I will get the amniotic fluid to get the karyotyping. That is a confirmatory testing. It's a confirmatory testing. Is it understood to all of you? Yes. So it is a simple test. Now anybody, when do I do it? What weeks of gestation is it done? So quadruple marker test or the triple marker test is generally done between 16 to 18 weeks of gestation. Is this understood to all of you? Okay, so please keep all these points in mind. Now can anybody tell me? So point number one is a screening test. Point number two, first let me discuss the triple marker test. Okay, so triple marker test, HCG, alpha fetoprotein, unconjugated estriol. Very good. Okay, it is not estradiol, it is estriol, ESTRIOL. This is the triple marker test. Now can anybody tell me, suppose if the baby is having trisomy 21, or that is your Down syndrome, what happens to these values? Again, values we are not supposed to remember. We just should know higher or lesser. Okay. So anybody, HCG, what happens? Should I put the arrow up or arrow down? 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 Yes, anybody? Very good. Yes, very good. All of you, excellent. Rahul, Bishnoi, and Samir and Elizabeth, and all of you correct. Okay, so please understand this, that if the baby is having Down syndrome, then HCG is higher than normal and the other two, alpha fetoprotein and unconjugated estriol, is lesser than normal. Okay. No, only one up. Okay, HCG high, other two arrow down. That is your triple marker test. Okay, so the question is triple HCG, alpha fetoprotein, unconjugated estriol. Okay, is it clear to all of you? So it is not estradiol, E2 नहीं है. Okay, and in the quadruple marker test, so this is your triple marker test, and quadruple marker test, the fourth thing added is our inhibin A. Okay, inhibin A. Okay, beta S you are not supposed to remember Edward. Remember in Edward all the three decreases. Okay, trisomy 18 अगर होता है, Edward syndrome is trisomy 18, all three decrease. Okay, is it clear? So don't remember about that. Then it's not going to be asked to. Yes, and very good. Inhibin A is again higher than normal. Just remember for trisomy 21. So I repeat, in trisomy 21, 2 up, 2 down. Okay, so 2 levels are going to be higher than normal, 2 levels are going to be lesser than normal. That is happening in trisomy 21, and that is our answer. That, sir, HCG, alpha fetoprotein, unconjugated estriol, and inhibin A is the quadruple marker test. Okay, it is not estradiol, and PAP A नहीं आता है. PAP A is done at the part of your dual marker test. Okay, so the answer option number A. Very very important MCQ. Please don't make a mistake. These are extremely high yield MCQs. I repeat, it's a screening test done on maternal serum at 16 to 18 weeks of pregnancy. Amniocentesis is a confirmatory testing. It's an invasive procedure. Okay, remember amniocentesis is invasive. What is the meaning of invasive? We are entering the uterus. We are entering the uterus, poking a needle inside the uterus and taking the amniotic fluid out. So screening test should be simple, easy. Okay, the screening test is simple and non-invasive. It is simple. Why simple? Easy. Just getting mother's blood. Okay, so non-invasive. Yes. Again, a very very important emergency contraception. Emergency contraception, when do we use? Suppose there's a rupture or boyfriend girlfriend meet. There's no plan of having sex, but they'll end up having sex. So unprotected intercourse, or rupture or tear in the condom at the time of intercourse. You have used a condom, again after the sex you realize that a condom is torn, or suppose it's a rape victim. So all these cases we need to give emergency contraception. What are the different methods also we'll discuss, and how do they act? No, S, please read the question. Except, it is except. So there are three. What it cannot do. All are actions of emergency contraception except. Okay, so point number 1. Emergency contraception, remember students. Yes, very good Samir. Okay, they are mainly called as interceptives. If they ask you interceptives, okay, so interceptives also remember. Okay, there another word is interceptive. What is the meaning of interceptives? So the methods of birth control, which act by making the uterus unsuitable for implantation. The uterus is, because the act of sex is already over, so the egg and the sperm may unite, but mainly they will make the uterus unsuitable for implantation. Okay, IMPL, implantation, everything. So the uterus becomes unsuitable for implantation. That is the main action. Okay. Okay, and it can also delay ovulation, and it can make the cycle, it can prevent the union. But all of you very correct. So yes, can it delay ovulation? Yes, it can delay. Can it inhibit fertilization? Yes, it can. And preventing implantation is also there. All of you, once it is pregnant, anybody, once it is pregnancy, what do I have to do? If it is pregnancy, either the patient continues pregnancy, or what else is the option? What else is the option? The only option is to go for MTP, medical termination of pregnancy. On that also now there's one more question coming up. So this, it cannot, please understand this, that the emergency contraception, very good Elizabeth. So the emergency contraception can never interrupt the early pregnancy. Once the implantation has already taken place, by giving emergency contraception, it's not going to cause abortion. Okay, interrupting a early pregnancy matlab I require abortifacient. Okay, we require abortifacient or have to go for MTP. Is it clear to all of you? So 1, 2, 3 all are possible by emergency contraception, but it cannot interrupt the early pregnancy, however early the pregnancy may be. Okay, whether it's just 2 days, 3 days, 5 days, once the implantation has taken place, we need to go for MTP. Is it clear to all of you? Yes. Now I want you to tell me what are the methods. Can anybody tell me what are the methods for emergency contraception? Anybody? That's also very important MCQ. Chalo, all of you must be knowing the famous brand name iPill. iPill is a brand name. We are not supposed to remember the brand name, but what does iPill contain? iPill is what? iPill is nothing but very good single tablet of 1.5 milligram levonorgestrel. Very good, all of you. So this is again asked to you that which is the progesterone used for emergency contraception. Pucha to LNG. Okay, it is effective up to how much? What's the emergency window? Up to 72 hours. Okay, up to 72 hours. You need to go within unplanned unprotected intercourse, LNG, IPIL, and even IUCD can be used. Okay, so lots of all this is discussed in detail in our actual classes. So IPIL, lots of other methods are there. IUCD, Julie Bristol, new thing has come out. All that is there. Okay, so IPIL is 1.5 milligram single tablet LNG to be taken within 72 hours of unprotected intercourse. Yes, again a very important topic. Which of the following is an indication for surgical management of ectopic pregnancy? That means if I have a ectopic pregnancy, most of the time I would like to go for medical management. What is the medical management for ectopic pregnancy? Anybody? Which drug is used? Methotrexate. Very good. Methotrexate injection we give. So in which condition, the MCQ is that which condition I will not give methotrexate, MTX I will not give, and I will prefer to do a surgical treatment. Yes, very good. Again, this was a previous year MCQ of FMGE and very likely to be repeated. So point number 1, anybody remember that when I want to give methotrexate, the following conditions have to be satisfied. Okay, so methotrexate is the drug of choice. Remember this. Okay, again a famous MCQ. Methotrexate is the medical management whenever they say for ectopic pregnancy, drug of choice for treatment or treatment of choice wherever possible. Point number 1, sir, patient, most important point for methotrexate, patient should be stable, yes or no? If the patient is in shock, can I give methotrexate? No. In shock, I have to go for emergency surgery. So patient should be hemodynamic stable. That means that it is only for unruptured ectopic pregnancy. Is this clear to all of you? Okay. Okay, so remember students that if it is a ruptured ectopic pregnancy, directly we go for surgical management. So yes, hemodynamically stable patient, I will go for methotrexate. Very good. Second point is that when we measure on ultrasonography, the gestational sac should be less than 4 centimeters. Some books say less than 3.5 that is also okay, but up to 4 is so less than 4 centimeters. Third point, anybody, how much? Very good, Prakhar. One more criteria. So stable patient, unruptured ectopic, gestation sac less than 4 centimeter, and what? And preferably the fetal cardiac activity should be absent, because if the fetal cardiac activity, baby heartbeat, it's called fetal cardiac activity, if it's present, then the methotrexate success becomes lesser. So fetal cardiac activity should be absent, and the HCG levels, very good, beta HCG should be less than, it should not be very high levels. Okay, 1000 but Yashwant 5000 tak chalega. Okay, it should be less than 5000 micro international units per ml. Okay, keep these points in mind. So if these 4 conditions are satisfied, always the answer will be methotrexate. So now coming to our MCQ, that where I will do if the beta HCG is less than 1000, very good, I will go for MTX. Cardiac activity absent, also I will go for methotrexate. Stable patient, all this I will go for methotrexate. The answer is, so if the gestational sac size is more than 4 centimeter, then it is a very big pregnancy, is likely to rupture, it can rupture, and therefore it is better to go for the surgical management. Is this understood to all of you? And here also, after giving methotrexate, how do I know my treatment is working? Anybody? After giving methotrexate is given IM injection, intramuscular. After giving methotrexate, how do I know my treatment is working or not? Yes. So here again we need to do a follow up of beta HCG, and beta HCG should keep on becoming less. Is this understood to all of you? So thoko tali, clap if you feel happy. To do 2 conditions. So following vesicular mole also beta HCG level should be checked, and following ectopic pregnancy given medical management methotrexate also HCG levels we keep on checking to make sure that the pregnancy is completely getting cleared, because the HCG is rising, or rising, then means it is, or plateauing, that means the methotrexate is not working, and I need to go for surgical management. Okay, is this understood to all of you? And yes, one more match the column time for the last time. Here there are different conditions. Okay, there are different conditions and different investigations. Which investigation I would do for endometriosis? Which investigation I will do for Asherman syndrome? What do I do if it's ovarian torsion? What do I do if it's for fibroids? Okay, so point number 1. Can anybody tell me again? This was this year. What is Asherman syndrome? So Asherman syndrome is intrauterine adhesions inside the uterus. So again, in my lectures I have told you about hysteroscopy and laparoscopy, and all of you know that if it is intrauterine adhesions, I have to go and do a hysteroscopy. I have to see inside the cavity. So hysteroscopy is to look at the cavity of the uterus. Very good. So when there is Asherman syndrome, I have to go and do hysteroscopy. So 2 is going with A, 2A. So this is out, this is out. Clear? Like that you should do match the column ka solving. Very good. What is endometriosis? Sir, endometriosis is presence of endometriotic spots outside the uterus. So you will see a chocolate cyst in the ovary, inside the ovary, and you will see red nodules, blue color nodule. Okay, endometriosis gives you very colorful picture. Khoon ke kitne rang? Okay, different colors of blood you get. Blueberry nodule, red raspberry, purple raspberry, all that we explained to you. And also gunshot, okay, powder burnt appearance or matchstick burnt appearance. So all this we see in the pelvis and the uterus. So I have to do laparoscopy. Laparoscopy is required to see the chocolate cyst, okay, and this. Okay, so laparoscopy is the investigational choice. So for endometriosis I prefer to do laparoscopy. Very good. Okay, so it is 1B. And when there is a torsion, if there's a torsion, what is important? Color Doppler, because color Doppler supply will be occluded when there's a torsion of the pedicle. So very very important for ovarian torsion, even for like the for your metatesticular torsion. Okay, so 3C. Okay, so 1B है, 1B, 1B, 2A, 2A, 3 is going with C. And for fibroids, we can just do a normal basic ultrasound 4D. So option C, very good, Dr. Rahul Bishnoi and MedPsych. Okay, so option C, not A, because A में क्या है, 3D है. Yes, ovarian torsion USG से better color Doppler. Okay, definitely. And fibroids normal USG is okay. Okay, so 1B, 2A, 3C, 4D, all these are important MCQs. Okay, so again with one MCQ, 3-4 MCQs. Okay, so I hope all of you had a great time today, and all these many MCQs, please do leave in the comment box your valuable important this and all thumbs up when you leave. And thank you very much for coming in today. And one more important announcement, that tomorrow also we are having a session. Okay, so tomorrow all of you please come in at 12 p.m. in the after 12 o'clock or 12:15 p.m. Tomorrow also there is 1 hour class. Okay, so 12:15 to 1:15 p.m. that is Saturday. Okay, Saturday, that is your 20th May. Okay, Saturday 20th May, part 2 of the same class we are going to discuss. So all of you should come in tomorrow also, like this kind of a quiz, some 10-15 MCQs. So today also we discussed more than 15-20 MCQs we've discussed in 1 hour time, and tomorrow also is a 1 hour class at around 12 o'clock in the afternoon, 20th May, for the part 2, and I hope all of you would be there. And please, those who haven't taken the subscription, take in as soon as possible using the promo code MENTOR, MENTOR, to help you get maximum marks. NEET PG Vitals, please check out, very important, and other packages are available, and join in as soon as possible. And also do not forget to appear for the test on 21st of May, which is at 10 a.m. to 1:30 p.m. Okay, so thank you all of you for coming in today. Wish you all the best, and see you again tomorrow for a very interesting session on part 2 of the FMGE quiz. Best of luck and see you tomorrow.